Yes, thank you, Dr. Khalid, for joining. We appreciate that you dedicated a time for us, though you are very busy in the clinic. So now, welcome everyone. In Kuwait time, it's good evening, everyone. Welcome for our third session in Bariatric Series, Back to Basics. Our session today is about bariatric surgeries, steps and procedure. Our speaker today is very special guest to us. He is a surgeon that I got to learn a lot during my training. Dr. Khalid L'Anizi. Dr. Khalid is a consultant general surgeon specialized in laparoscopy and bariatric surgery working in Amiri Hospital. He got his Canadian Board of General Surgery in McMaster 2001. And then he got his fellowship in trauma and laparoscopic surgery also in Canada 2003. He is a fellow of the Royal College of Surgeons, Canada. It's a pleasure to have you, Dr. Khalid, with us, and you can start your session.
It's my pleasure, Shema, to meet all my dear friends, residents, and inshallah will be my colleagues down the road. Thanks for inviting me for this session. We're going to talk about basics. I always say, what do our residents miss in training? When I was in Canada, but don't be sarcastic, please, okay? When I was in Canada, there was something that we were missing. Shema, I don't see you anymore. Do you guys see me? Shema, ما أسمعك.
لا, I just off my cam so the attendees can concentrate on you, Dr. Khalid.
Well, that's okay. So when I was in Canada, and I know many people are being sarcastic about this phrase, but there is something missing. And in every training program, whether in Kuwait, in North America, in Europe, in the Gulf areas, or in Asia, there is always some missing, some things which the resident don't get a lot of exposure. For example, when I was in Canada, we had a problem there with the pre-op and post-op follow-up because of the system there. The patients were all seen by the consultant in their offices, and the resident usually don't go to the offices. We see the patient on the table. We operate on them, and they go home, and we don't see them post-op. That was a missing point. We don't have it in Kuwait because most of the residents, they have clinics, which is a good point. Now, what we miss in Kuwait, we miss the small little tricks and steps that we need in surgery. Most of the residents here in Kuwait, especially when we do big cases or advanced laparoscopic cases, they come when the patient is ready to have the operation done. So the resident come, do the cutting, and come out. But there are some steps which are important. It's like when you fly, you just book your ticket, you sit on the seat, and everything is done for you. So I thought we will go with the important steps in all bariatric surgery. I'm going to talk about the steps in general. I'm not going to talk about the certain steps for every bariatric procedure. We might, at the end of the session, talk about different steps in every specific procedure. Let's look at, first of all, the position. Position is very important in all procedures. There are two main positions in all bariatric, either supine, and remember, we don't do it a lot in Kuwait here. We don't see it in Kuwait, but this is the position. The beds usually come with support for the feet. The other position, which is more common, is the lower down, which is we call it the semi-lithotomy or split leg. The advantage of the split leg is you have the between legs space for the surgeon and the assistant. Important thing is to position your patient. I don't know whether the cursor is clear. You have to position your patient so that the hip is at the point where you can flex the table, because sometimes you need to put the head up. The advantage of the one supine position is you can stand up your patient. You can work on a patient almost in a stand-up position. Okay. Important other things is padding of the joints, the legs, the feet. We have so many patients complain of neuropraxia of many nerves, especially the upper and lower limb. So it's very important to track your patient. Now, let's talk about now the port's location. It's very important when you do any procedure to locate your patient, your port. See the picture on your right-hand side, the left side of the screen, there are so many port sites, as you can see. The most common, the one on your left-hand side, which is this one. Usually we use, if you have a 5mm camera, usually this is the site for the camera, and then you need one, the subxiphoid, one on the anterior axillary line on the left side, and one on the right side, and the camera. Most of them are above the umbilicus. Now, there are many surgeons who do it through the single port, through the umbilicus. We're not going to talk about we're going to talk about the techniques that are used most commonly by most of the surgeons. Now, where you put your ports? Do you put them like 2 centimeters below the xiphoid sternum? Do you put them 2 finger breadth or 2 centimeters above the umbilicus? In obesity surgery, usually the configuration of the abdomen differs from all patients. So I usually don't like to say you have to put your epigastric port 2 centimeters below the xiphoid sternum, which is not accurate. Usually, when you put your camera, the difference in the position of the camera depends whether you're doing a sleeve, a band, or you are doing a bypass. If you are doing a sleeve gastrectomy, you need to go up, because what's important to you is the GE junction and the crura. So you need to put your camera as high as you can. If you are doing a bypass surgery has 2 components, gastric dissection and small bowel. For the small bowel, you need to go really low down. Otherwise, you will have problems visualizing the small bowel anastomosis. So in summary, in sleeve gastrectomy or banding, you need to go up with your camera. In bypass, you need to go down. The lower you go, the better. And then you put all other ports based on what you see inside. Sometimes you find huge falciform. That's one trick, remember it all the time. If you have a big falciform, then go with your right upper quadrant port. Go as lateral as you can, because this gives you more room to move your ports so that you can grasp and everything. And if you have a big liver, especially the left lobe, and it's lying all the way down, you can manipulate better with a laterally positioned port. I hope this is clear. So the summary is, every abdomen is different from the other. You need to put your camera and then put your ports according to what you see. Now, what are the ports we use? All of you guys, you use whatever the nurses give you. They give you the port, you go with it. And all of you, majority of you do, the most common procedure is lap chole. Lap chole, you go through the umbilicus, you have fixed points. So whatever port you use, most of the time it's safe. In obesity surgery, we go up. If you go up, there are no landmarks there. So you don't want to injure any intra-abdominal organs, mainly the vessels. That's the nightmare for all of us. So there are 2 types of ports. You have the visi port and the non-visi port. The visi port is you put your camera in, preferably 0 degree. You go in and you go under direct vision. The non-visi port, we have the bladed and non-bladed. And the bladed, see, there is a knife there. As you push through, the knife, the sensitivity of the knife differs from one company to another. We commonly use the Covidian or the Medtronic. I don't like them. I hope nobody here is a pro Covidian. I don't like them. I like the Ethicon ones because Their knife is very sensitive to pressure. So as soon as it goes through the peritoneum, the knife slips in and you are safe. Whereas the Medtronic one, sometimes it takes longer time for the knife to go in. And this exposes you and the patient for injuries which might be very serious. Now, to summarize about the ports, you have to be careful. You have to be careful in all type of ports. The busy port does not mean that you see everything and you will not injure anything. I have seen a case presented in a conference here in Kuwait, in Acupass. The aorta was injured with a busy port. The surgeon was going directly under direct vision. So it's very important to be careful. Even if you do thousands of cases, in every case, consider yourself, this is the first time I do it. In my life, I have believed that whenever you feel that you are too confident, you cause complication. So please don't be overconfident. Always go back to the level of R1, even if you are a serial consultant. In this way, you are safe. Okay, now let's move now to the sealing device. The sealing device, we use NC, we use ligature, we use harmonic, and these things. There are two principles for sealing device, either the electrocautery or the ultrasonic. Or we have the combination. I'm going to talk about them. The electrocautery is like the cautery, but we use bipolar, which is the ligature, it's by Medtronic, Covidien Medtronic, or the NSEAL, which is by Ethicon. And these usually use electrocautery, use electrical energy, and these are safe in all patients. The good thing about them, they are very well insulated. So even if you go blind, you are not worried about the tissues and the structures around you. Which one is better? It's surgeon preference. I love NC. Harmonic, this, as I said, ligature and NC use electrical energy, whereas harmonic uses ultrasonic waves. So if you look at the harmonic, look at this small blade. This is the active blade. The active blade, usually it's very hot. So it's very important for you when you go in, make sure you see the active blade, because if you don't see it, it's very hot. I personally injured the spleen and my patient bled a lot. I have to spend 1 full hour to stop the bleeding from the spleen. Thanks God. We managed to do it laparoscopic. It's the hot blade. So the harmonic, when you go on, you should never go blindly. Now we have something called the Thunderbeat, which is combination of harmonic and electrocautery. You see the two buttons. One of them is harmonic, one of them is electrocautery. You use, again, whatever you like. But remember, when the active blade is exposed, you have to be careful and sure that you're not touching important structure. I have heard about patients who had injury to the esophagus from the harmonic scalpel. All of you guys have used staples. The principles of staples is all of them are made of titanium and some element of nickel, but it's mainly titanium, which is MRI compatible. So if patient had any abdominal surgery and staples were used, they're fine to do any MRI. You know the conventional staples, and the height, usually it's 3 lines in each side. In between is a knife. Medtronic invented the tri-stapler, which means the 3 staples are of different length. And the reason for that is the shorter one will give you better control of small vessels, and the bigger ones will give you a control of the thickness of the tissue. For me, I don't see any differences. Now, what are the colors? I don't know whether I'm allowed to make it interactive or not, but let's talk about the colors. You guys have done so many bowel obstruction, open surgery, and you have used staples. Have you ever asked about ask the nurses what color you want. Most of the time, we just take the stapler from the nurse and we just fire. Now, in advanced surgery, you have to make sure and you know what staples you use, especially in the upper GI, because of the difference in the thickness of tissue. That's why we have different colors. We have the blue color. The most commonly used are white, which unfortunately I haven't shown it here, blue, green, and black. These are the most commonly used. The gold is also a good one, but it's not available most of the time. So look at the blue one that you guys used most of the time and the white ones. The blue one, it's 1.5 to 2.4. So what we do, the green is thicker and the black is more thicker than all of them. Now, when do we use which one? For the sleeve gastrectomy, the antrum is the thickest part of the stomach. So we don't use the blue one, we use the green or the black. What's the advantage of the green and black, and what are the disadvantages? The advantage, it's big staples, big clips, they close well on the tissues. The disadvantage is that because they are big, wide, they might not give you good control of blood vessels. So you see your staple line bleeding. So if you see your staple line bleeding, this means that your clips are slightly bigger. Okay? So for the antrum, we use green or black. I personally used black maybe 2 or 3 times in thousands of cases. Even the redo, I usually rarely use black ones. Now, after the antrum, we go up on the body and then on the fundus. The fundus is thin, and most of the time, blue is more than enough for the fundus. The body of the stomach, most of the time, is blue, but sometimes in patients with thick stomach, you need to use green. Now, for the tri-stapler, purple will do the job for all the other colors, except for black. So for the purple, you can use purple from the first firing on the stomach from the antrum all the way up to the GE junction. Now, one thing to remember, patients who had who are going for revisional surgery, who had previous surgery before, their tissues are very thick, and usually you need to use green. I personally, for re-sleeve, I don't use blue at all. I use green or black. And as I said, black, I rarely use it. Patients who had balloons before, those patients usually, their stomach becomes bigger and the stomach wall becomes thicker. So most of the time, put in your mind, if you want to do a sleeve for a patient who had a balloon before, make sure you have enough green reloads plus minus black reloads. Now let's move one step ahead now. These are the reloads. Now let's talk about the stapler. All of you know the most two common staplers, the Ethicone, which is, this is the Echelon, which is made by Johnson & Johnson, and the Tri-Stapler, which is made by Medtronic, Covidien. What's the difference between them? Now, we have so many other brands of staples. All of them are based on the same principle. They use titanium and nickel. The height of the staples is the same. The mechanism of firing is different. In Echelon, usually what we change only the reload. The knife is fixed. You change only the reload. Okay? One point I forgot in the previous slide is the white reloads. We use white reloads for small bowel and for vascular. That's why the vascular surgeon, hepatobiliary surgeon, they use it a lot. For the small bowel, white or blue, not green at all. So back to the staples. Echelon comes in many different staples, either the automatic, the battery operated or the manual, but the firing is the same. They have what we call the articulation, which goes up to 45 degrees. For Medtronic or Covidien, the traditional staples, their reloads come in separate knife. Every reload has its own knife, but you have to change the whole shaft. Whereas in Echelon, you only need to change the reloads. The knives are fixed. But lately, and I'm sure you guys have noticed that Medtronic or Covidien has changed its staples, and they made it like Echelon, so you don't need the whole shaft. The staples comes with a reloader, which is the shaft, and different reloads like this. So you change only the reloads. Which one you use, it's the same. It's surgeon preference. Company usually advise you to, after you apply your staples, to wait for a minute or so in order for the water to escape away, so your stapling comes right. I don't believe in this. I don't believe in this because after thousands of cases, and I don't wait at all, I have noticed no difference between them. What makes the difference is applying your stapler on the tissues. It's very important to make sure that your tissues are even when you apply your staples, because if they are not even, you will get areas which are thicker, and you see that these areas are bleeding. This will not harm your staple line, but it makes it looks neat if you take care of it. Now, let's go back to the stapling again. Now, when you fire your staples and you find it's bleeding, you have to ask yourself, why? Is it the type, the color of the reload that you're using, or it's your mechanism of not holding the tissues? This makes the difference. With time, you will get to learn it. What I usually do, after I apply the stapler and I close it, I'll wait, and then if I don't like the way the things are together, I just open it and close it. You know what happens when you do that? Sometimes one part of the stomach is pulled inside more. So when you open it and release it, it just relaxes between the jaws. So when you fire, the firing feels better. One more common problem we see is when you fire and you reload is smaller, you are using the inappropriate size, you will see serosal tear. Don't worry, serosal tear will not really affect anything. Let's go back now, tricks. Now we'll talk about sleeve gastrectomy. The three most important tricks is dissection of the greater curvature, dissection of the big fundus. A lot of teenagers, they eat a lot at night and they sleep, and the fundus is so big and it's so deep behind the spleen, it might be very difficult to get it out. And then the left gross dissection. For the dissection of the greater curvature, you need to go into the lesser sac by any means. You just hold the stomach, cut and go. When you go to the lesser sac, to avoid bleeding from the greater curvature, you have to go close to the stomach wall. Because if you go a little bit away and you leave some fat on the stomach wall, you increase the chance of bleeding from the omentum. So my advice to you is just be very close to the stomach wall. That's fine. Burn the stomach. It's not a big deal. You're going to take it out. And even if you decide not to take it out, you can just invaginate it with a stitch. You can do it all the way. It's very easy. When you come to the left cross there, and if you face a big fundus, what should you do? Remember, if you start dissecting more distal to the cross, things will become easy. The epigastric port to me is very important because your assistant not only raises the liver with it, it pulls the fundus from down and lifts it up this way. okay? And ask your assistant to push the antrum away into the right side. And then when you go with your dissection, just pass the left gastric and start dissecting as if you are starting at the distal end of the crus. And this way, this will open the space between the crus and the spleen. This gives you a lot of exposure and you can go up. You see many times that your spleen goes purple in one part of it and it goes ischemic. That's fine. It's not a big deal. You should not have any problem. In years of working in surgery, we have seen only one patient in Amiri who developed an abscess in an ischemic part of the spleen, which was managed with the interventional radiologist. That was about 10, 12 years ago. But the patient did fine after that. Now, for the sleeve gastrectomy, we have the standard steps, which is cutting the transecting the stomach proximal to the pylorus. You can go 2 centimeter, you can go 6 centimeter, but you start from there going all the way up to the GE junction. Try to leave a space 1 centimeter from the GE junction. Important trick. Sometimes you look at the stable line anteriorly and you see that you are far away from the GE junction, but in fact posteriorly your stables at the GE junction. That's why we see most of the leaks are posterior. So it's very important for you when you put your stapler on at the last firing at the GE junction, flip your stomach and see the esophagus posteriorly. Otherwise, you're gonna injure the stomach esophagus and you get leak. And take it from me, leaks happen. Let me say it again. Leaks would not happen if you stable stomach to stomach. Remember, guys, the stomach is your friend. Don't worry about it. Leak will never happen again. Leak will never happen if you staple stomach to stomach. Leak will happen if you staple stomach to esophagus. Leak will be inevitable. So make sure in the last firing you flip it. Okay, another point. Sometimes not the last firing, the firing before, the tip of your reload reaches the esophagus. So the last 2 firing, please be careful. Make sure you look posterior, leave part of the stomach. Again, remember, if you leave 1 centimeter extra of the stomach, this will not affect the weight loss. But if you make it tight, you will compromise your technique and this will result in leak. You better leave a patient with not a good sleeve. They don't lose a lot of weight, better than giving them a leak and make their life miserable for the rest of their life. So these are the principles. Now, what's the controversial? Controversial is the buttressing material. Some surgeons they use seam guard or peristrip. Both of them are bioabsorbable buttressing material. We used to use them. I personally don't use them because I don't see them giving us any difference in outcome. In fact, for me, when I use them, my sleeves are really ugly. But many surgeons use them. So these are controversial things, difference between surgeons. Application or khiyata taghlifiya, the same thing. Many surgeons, they don't advocate, they don't like it. Some literature suggests that it increases the leak rate. I don't believe in it because if you do it right, in my personal opinion, if you do the application right, you should not have leak. But this is again personal preference. Whether to suture an application way or you do it through a through, it doesn't matter. I personally don't like through and through because I find it does not give you a better control in bleeding. Amantopixy, which is الخياطة اللي هو منديل المعدة. You see many surgeons doing it. I used to do them 8 years ago. I did for 50 patients, and I found that they vomit in the first 3 months more than the others. And it makes sense because the omentum is very heavy. So when the patient stands up, it pulls in the stomach and it causes a twist. And this causes more vomiting. And we have noticed the registrar that works in the hospital, in the private hospital I work in, they follow the patient. And they told me, because one of the surgeons is doing the omentopexy, and those registrars follow the patient of all doctors, Dr. Shahab, Dr. Dalal, Dr. Imad, you know them all. And they say, doctors of this surgeon who uses omentopexy, they vomit more than all other patients of other surgeons. So I believe omentopexy causes more twist in the first 3 months, so I don't use it. We come now to the other modalities like using the glue. Again, glue is something that's used in all anastomosis. I don't use it. I don't see of any extra value for it. The last point is extraction of the stomach, whether you use a bag or not. What's important is try to relax the patient. What happens if the stomach ruptures and the gastric content spills in the abdomen? It's not a big deal. It has happened many times. You just suction the mucosa, suction everything, nothing would happen. Does it increase the risk of intra-abdominal infection? Theoretically speaking, yes. Practically, I had so many patients, none of them had an intra-abdominal infection. One patient had a wound infection from that, but none have intra-abdominal infection. The last point is closure of the ports. I personally close only ports which are bleeding. I don't even close 15 millimeter ports unless they are bleeding. If you close them, please make sure you close them tight, not very tight. Don't leave space between your sutures when you close it. I had a patient, I was too tired and I just did the closure very quickly, and the patient herniated between the sutures and came to me with bowel obstruction. So it doesn't matter whether it's a bladed or non-bladed. If it's bleeding, close it. If it's not bleeding, I don't see a reason why should you close it. I sometimes close it in patients who had abdominoplasty and their muscles are very tight. I close it because the port site is always open, and this might increase the risk of herniation. And I think this is the last one. I wrote Islam in Arabic, means thank you for your attention.
Thank you, Dr. Khalid, for your amazing session. It's full of special techniques and tips that we would never find in books. It's based on your long experience in this field. There is one question in the Q and answer from Dr. Muhammad Taqi. He's asking how to appreciate thickness of the stomach to choose the color.
Yes, that's a very good question. See, there are new staplers that I have not talked about, like iDrive, which has it's computerized so it can sense the thickness. I don't see any value for that stapler because with time you get to know. Simple technique is when you close your stapler, you don't need to have a lot of experience to know. When you close your staplers and you feel that it's really harder than normal, this means that your tissues are thicker than the reload. In this case, you have to change your reload. Or sometimes you are not spreading the tissues well, and the tissues are crumbled all together. So when you close your stapler, you feel it's thick. In this case, that's what I did earlier. I said earlier, just open, let the tissues release, and then close it. You will find it going well. If you still feel that it is thick by closing, it's really hard. This means that your tissues are thick. It's a matter of time, and you get to know the thickness with experience.
Thank you. Is there any question further for Dr. Khalid? Okay, Dr. Khalid, we have another question from, again, Dr. Muhammad Taqi. While accessing the lesser sac, is the distance from the antrum important?
Yes. Muhammad, I like this question. I personally believe we should go as close to the pylorus as possible, because I have seen as possible, because I have seen better results when I go close to the pylorus. Sometimes positioning of your ports will not let you go close to the pylorus. In this case, you dissect as close as you can with your instrument. If I can reach down to the pylorus, I will do it. If you are not going close to the pylorus with your stapling device, you should not go that close. You just go 1 centimeter distal to where you are planning to put your stapler.
Okay. Third question from Dr. Ghada Al-Barrak. She's saying, why just we undergo with a greater curvature sleeve as is the safest? May big fundus sleeve cause hiatal hernia or GERD?
Why just we undergo with a greater curvature sleeve? مو فاهم السؤال.
Yeah, me too. I'm not sure that I can understand what's the questions, Dr. Ghada.
هو طبعا شوفي غادة أنا you need to elaborate more in your question. Part of it I'm going to answer on it. If you leave a big fundus, this causes high chance of reflux. And we have seen it in many patients with retained fundus. They complain of a lot of GERD reflux. But it's nothing to do with the hiatal hernia. Big retained fundus will result in regurgitation of acid spore, and this gives the patient a lot of reflux symptoms. But this is not related to the hiatus hernia. I'm going to answer Muhammad, and she's going to look at the answer. Is dissection of the left crust can lead to reflux and intrathoracic migration? How to adjust it? صح Muhammad. Over dissection in the left crust might result in attenuation of the ligaments that hold the stomach, and this will increase the chance of intrathoracic migration. And it happened with me in a few cases and in many surgeons, and we have seen a lot of cases presented in international meeting. What you need is just try to avoid over dissection of the left crust. Try to keep the peritoneum on the left crust. Two of my patients, they herniated, and when I reviewed the CD of the operation, I found that, in fact, I dissected the peritoneum that was covering the crust, and the muscle fibers were very clearly exposed.
Okay. There is, we'll take this last question, Dr. Khalid. It's written in the chat area from Dr. Ali Al-Khayyat. Do you have a specific consideration of super obese in padding? And have you had patients with buttock ischemia while in supine position?
And I'm not getting the question. Ask the question again. When in chat?
It's in the chat, yes, it's in the chat.
Do you have specific consideration for super obese in padding, and have you had patients with buttock ischemia? Alhamdulillah, I have never got problems with ischemia and pressure ulcers with patients. I've never had rhabdomyolysis, but we have patients in one of the private hospitals about 8 years ago. Unfortunately, she died because she developed renal failure and these things. But we never had it. Padded is mainly important for the joint and superficial nerves. We had, I think, couple of patients who have peroneal nerve neuropathy and foot drop, and we commonly see patients with symptoms suggestive of lateral cutaneous of the thigh entrapment, and it's a very annoying symptom. It's not really a serious complication, but it's very annoying You will see many patients complain of numbness over the lateral aspect of the thigh. The question بعد؟
لا بس غادة البراك I think she tried to elaborate more about her question. She's saying, I mean, in which cases we must undergo the fundus sleeve, and I'm grateful for your effort. It was informative.
fundus sleeve. مو فاهم السؤال غادة، اسمحي لي. I mean, which cases you must undergo the fundus. يعني تقصدين يعني متى احنا we leave the fundus ولا تقصدين الحالات اللي الفندس كبير نشيله؟ ما فهمت، سوري غادة. خلينا نشوف السؤال.
I think Dr. Ghada, you can send your question through our email and we'll try to send it to Dr. Khalid and get it answered for you. Thank you, Dr. Khalid, and thank you for your time and joining us. Inshallah, we'll have you another session soon.
مشكورين، ما قصرتوا، والله يعطيكم العافية، وإن شاء الله يعني أتمنى لكم كل خير. أنا إيميلي موجود، واللي يبي الدكتورة شيماء تقدر تعطينهم شو اسمه تليفوني، أنا I can answer all the questions، وأنا حاضر. اللي يبيني أساعده بأي عملية أي شيء أنا حاضر.
تليفونك لا.
لا عادي، ترى على فكرة شيماء، إذا أنا تليفوني أعطيه حق مرضاي، وهذه نقطة مهمة جدا، لأن أنا دائما أفضل أن مرضاي they call me when they have problems. They don't go to the emergency room because we have lost one patient because the patient went to the emergency room with bowel ischemia, and the emergency physician doesn't really appreciate the importance of this thing, and he was kept 10 hours in the emergency room on an IV fluid 50 cc per hour. And then he came with ischemia all of his bowels. But I prefer to give my phone number to all my patients, and they're never annoying me. In fact, let 10 of them annoy me, but I save one patient, that's better. So you can take my telephone number, anybody can send me on WhatsApp. ما أرد على اتصالاتكم, don't call me, I'm not going to answer, just send me WhatsApp.
يعطيك العافية دكتور Khalid. We'll definitely share the contact, email, social media, and if necessary, Dr. Khalid's number with the attendees. Thank you very much.
حاضر، ويعطيكم العافية كلكم.